Hello and welcome everybody to our TIF Talk tonight. I'm very excited to have our special guest all the way from Phoenix, Arizona, Dr. I knew I was gonna mess it up, Mankanwal Sachdev. Hi, Dr. Sachdev, and thank you for joining us tonight.
Hi, Andrea. How are you?
I'm well, thank you. In addition to our special guest, Dr. Sachdev, we have Karen Girth, who is one of our market development managers. She will be live on with us tonight as well, answering all the questions, or I should say asking all the questions that you guys asked tonight on our segment. So welcome, Karen, and thank you for joining us.
Thank you.
So as you all know, our TIF Talks on Tuesday are live. So at any time, if you have any questions for Dr. Sachdev, please feel free to type them into the chat section and we will do our best to answer all of the questions. Before we start, I do want to give you a little bio on Dr. Sachdev. He was previously an assistant professor of medicine and Department of Gastroenterology and Hepatology at University of Tennessee Health Science Center in Memphis. He has also been an instructor of medicine at the Feinberg School of Medicine at Northwestern University of Chicago. And presently, he holds the academic rank of clinical assistant professor of medicine at both Creighton University School of Medicine and the University of Arizona College of Medicine, Phoenix. He has completed fellowships in gastroenterology, transplant hepatology, and therapeutic endoscopy. He is presently the Medical Director of Endoscopy at both St. Joseph's Hospital and Medical Center in Phoenix, Arizona, as well as Arizona Advanced Endoscopy in Gilbert. He is also the Program Director of the Advanced Therapeutic Fellowship at both St. Joseph's and Arizona Center for Digestive Health. Again, Dr. Sachdev, we can't thank you enough for joining us tonight. We're really excited to talk to you today.
Oh, thanks for inviting me and having me. It's a pleasure to virtually meet everybody. So
perfect, thank you. So let's get started, Dr. Sachdev. Do you want to go ahead and explain what is GERD? Maybe talk a little bit about, what could patients potentially feel if they were suffering from GERD, maybe some atypical and typical symptoms and whatnot.
Yeah, absolutely. So GERD, is an acronym for gastroesophageal reflux disease. And basically there's two varieties. There's acid reflux and there's non-acid reflux. And the one that's most commonly what most people are thinking about is when they talk about GERD is the acid reflux. It's a situation where your esophagus and your stomach are separated from one another by a muscle called the lower esophageal sphincter. And that muscle is reinforced by the diaphragm. And so I like to tell people to kind of think about a Ziploc bag that has two of the zips on it. You put them together. And so what the stomach does is you eat your food, it goes in there, and the lower esophageal sphincter opens to let the food in, but then it closes. And the diaphragm reinforces that. So if you were to put a piece of meat in a Ziploc bag with marinade and zipped it, you could throw it up in the air and nothing would happen. What happens in reflux is that these things get misaligned, either because you have a weaker sphincter or you have a bigger opening for the diaphragm, or in some people just you overeat and that bag gets too full. And so as the stomach is trying to digest the food, it pushes acid and food contents in the esophagus. The esophagus isn't meant to deal with acid. Its lining is not made for that, but the stomach is. So when you get acid and food contents in the esophagus, it hurts. And that's kind of where you get heartburn symptoms. That's kind of my layman explanation for people.
I love it. Yeah, I've never heard of it. I've never heard that analogy of the Ziploc bag, but it makes perfect sense. So thank you. And maybe talk a little bit about, how is GERD diagnosed? What types of testing does someone have to endure to determine, do they really have GERD or is it something else?
Yeah. So most patients will come to us with symptoms of heartburn, right? And so heartburn is the number one complaint. And, I think when we look at the medication market in the United States, acid blockers or proton pump inhibitors and H2 blockers, so medicines like lansoprazole and omeprazole or famotidine, they are probably responsible for a majority of out-of-pocket or insurance claims. So it's a very common problem, and most people self-diagnose with the symptoms. But testing specifically for reflux can be something as simple as an esophagram, which is where you do a barium swallow, or something as intricate as a manometry study or a pH study, where a doctor will place a catheter through your nose into your esophagus and use that probe to measure different pHs or pressures, and pHs and pressures in the esophagus. And then the other way is endoscopy. Endoscopy will not necessarily diagnose reflux, but it will diagnose changes because of reflux, like esophagitis or a hiatal hernia, which can promote reflux, or just any other abnormalities, H. pylori, which is an infection in the stomach, which can promote acid production that can in turn lead to that. So definitely a wide variety of tests that can be done. But most of the patients we see in our practice are coming to us saying, "Doc, I have heartburn." And then we kind of get into the history and figure out, is it reflux or is it something else?
Yeah. And, what do you normally do or what do you tell patients to do kind of initially to manage their GERD? I mean, you talked about medical therapy, but even before that, there's, lifestyle modifications, losing weight, all that kind of stuff. Can you talk a little bit about that?
Yeah, so kind of to kind of understand that, I think if we go back to my analogy of the Ziploc bag, right? So we have to figure ways to not increase the pressure in the stomach and allow acid or food contents to go into the esophagus. So one thing that we tell people to do is raise the head end of their bed at nighttime to 45 degrees. That's usually helpful for a lot of patients, not for a majority, but a lot of patients do get benefit. There is a disadvantage of that, because if you have a spouse or a significant other, you can't raise both ends of the bed, because then people are sliding down all day. But that does
get those
help.
adjustable ones.
Yeah, like sleep member beds or whatever. But I think the main thing though is that a lot of folks try to do it with pillows, and you actually have to raise the head end of the bed using either an adjustable bed or 2x4s under the head end of the bed to kind of create it, because pillows you can sink into. That's the first thing. Second, you hit on it, was weight loss. The number one cause for, or not number one, but one of the top causes of acid reflux in the United States is obesity. The country is getting heavier. The pandemic didn't help that matter at all. But people, if you look at the CDC's website for obesity in the United States, there's some really nice and revealing graphs that show what the average person weighed in the 60s, 70s, 80s, etc. And blue is the thinner you are, and red is dangerously heavy, and the country is turning red in that regard. And so obesity is a huge reason. So weight loss is absolutely a must for anybody who wants to control their reflux. Exercise helps. We do tell people to minimize caffeinated beverages like coffee and chocolate. Unfortunately, some stuff that we all love. You can't have chocolate and caffeine. I mean, not that you can't, but if you eat it, you'll notice it more. Try to decrease the amount of acidic foods that you eat or drink, like orange juice, and other things like really greasy and oily foods will cause. Not only will they cause discomfort, but they can also physiologically cause the sphincter to relax a little bit more. So those are kind of the home things that we would tell people to do. And when and if you fail that, then your next step is currently medical management, and that does include proton pump inhibitors and H2 blockers. Proton pump inhibitors were the number one prescribed medicines. And over the last probably 5 to 7 years, there's been a little bit more research coming out about the side effects of these medicines. And there are some concerning ones that occur with long-term use. And one thing I want to stress on the audience here is that a majority of these side effects are not going to happen if you use the medicine for 6 months, 6 weeks, 1 year, but it's more when you're using it for 5, 10, 15 years. Long-term use of these medicines can lead to weak bones. There are some case reports, or some, not reports, but literature reports suggesting dementia and heart disease, some thoughts of kidney disease as well. So There are some significant side effects. The good news, I don't want to freak out people on this, is that if you're using them, a majority of people don't get these side effects, but they are present and they are concerning. And as we learn more about it, with more years of people taking it, we're probably going to find out that there are other things that can happen from this.
Yeah, I'm glad you brought that up, because that's one of the big questions that everybody has or patients are concerned about. I've heard this or that about long-term use of PPIs. I've been on it for 5 years. I've been on it for 10 years or whatnot, longer sometimes. And I guess one of the questions that I'd like you to speak to is, at what point, because we get this question all the time, at what point does a patient say, when is it time for me to go in and do something other than continue taking those PPIs?
Yeah, so I think for we have guidelines. So that one of the things that's really important about reflux disease is that long-term uncontrolled reflux is a risk factor for esophageal cancer. It used to be that the picture of people getting esophageal cancer was the same picture as people who have Barrett's esophagus, which is, generally speaking, a male who's middle-aged, 40 to 60, who's got, a little obesity, a paunch, and he's got acid reflux. Smokers are more likely to get reflux as well. And so these were the guys that had Barrett's, and a lot of the guidelines have been focused on that Caucasian males who are heavy, who smoke, who have uncontrolled reflux need to get an endoscopy to evaluate them for Barrett's. And so I think that was the person who was initially coming in to get evaluated for GERD. But as I mentioned earlier, the country's getting heavier. Tobacco use is probably a little bit better than it was 10 years ago, but we're seeing that the behaviors between, if we look back at how social behaviors with men and women were different in the 60s and 50s, where people are doing the same things despite your gender, we're starting to see more people get reflux, or more women get reflux. So I think when you have uncontrolled symptoms, that's one reason to come in. The other one is that when you're on these medicines for long term, it doesn't really fix the issue. It's just minimizing the symptoms, right? So you're decreasing acid production with an acid blocker. But are you fixing the key problem, which might be your obesity, might be your smoking, but usually it's with your sphincter being weaker or the diaphragm not being able to support that.
Yeah, that's a good point. So before I see quite a few questions popping up on Facebook. So before we continue, I'm going to pass it over to Karen and let her ask some of those questions that are popping up on Facebook.
Thank you so much, Andrea. We do have a couple questions, and we have a question from Lauren, and she has had her gallbladder removed, and she's asking, does that lead to reflux or GERD or any type of bile reflux?
Yeah, so thank you, Lauren, for the question. So yeah, I mean, for acid reflux, no, but there is a condition, a bile reflux. And so when a person does have their gallbladder out, and this might be a little more detailed than everybody wants to know, but I'll kind of explain it, that your gallbladder is a reservoir that holds bile. So your liver makes up to 2 liters of bile a day. And as it releases it, it goes into your gallbladder, which stores it. And then when you eat food, your brain sends a signal to the gallbladder that, hey, food's coming, so it squeezes. And when it squeezes, it releases all that bile into the intestine to mix with the food so that you can digest it. When you have your gallbladder taken out, as many women do, and men, but mostly in women, you don't have that reservoir anymore. So your bile duct, which is a tube that originally connected the the gallbladder to the intestine, or the liver to the intestine, stores that bile. And what ends up happening is it releases bile more frequently than it used to. So you almost have like a leaky faucet in there. And that's just a natural side effect of the procedure. It's not that your doctor did anything wrong or anything like that. It's just the way the anatomy and the physiology works. So when you're constantly dripping bile into the intestine, sometimes it goes instead of going down the intestine, it goes up the intestine into the stomach. The opening of the bile duct from where the stomach ends is literally 2 inches away. So bile can get into your stomach, and then, depending on what you're doing, if you're lying down or if you're eating a late meal, that bile can come up and irritate your esophagus. And at the very beginning, when I talked about reflux, I talked about acid reflux and non-acid reflux. So that would be an example of bile reflux would be in the non-acid type, even though bile is an acid. So it's all kind of similar, but it's not gastric acid. So
Gotcha. That's good. Yeah, thank you for explaining that. Karen?
So I know we haven't quite gotten there yet, but I think it's coming up. The options that you have, surgical options, specifically a TIF. So there are some questions coming in about the TIF procedure, and people just wondering what the testing is like for that.
Yeah, so absolutely. So just before we get into, I guess one thing that I hadn't got to is the surgical options. So generally speaking, a fundoplication or a Heller are the two surgical options that are out there. And those basically will kind of tighten up so generally what happens is when you have a weaker diaphragm and a weaker lower esophageal sphincter, you have what's called a hiatal hernia. So those procedures are meant to help repair that. And they used to be surgeries that were done open, then they became laparoscopic, now they're becoming robotic. But a TIF is the same procedure, but it's done internally through your mouth. So that's why it's called transoral incisionless fundoplication. So this is a procedure that, that we're going to be talking about in more depth today, but we go into your stomach and we use this device to help anchor, for lack of a better term, the stomach and the esophagus together to tighten up that area. In order to qualify for that, what you really need to know is, what is my reflux, how many years I've been having reflux for, what kind of medications I'm on. And then the question becomes, should we consider decreasing those doses of those medicines or getting you off of them altogether? And so in order to do that, we have to fix the problem, which is to tighten up the sphincter. And that's what a TIF accomplishes. So the testing would be, number one, just to determine, do you truly have reflux? Are you on the right medicine? There are a ton of patients who are on acid blockers who don't actually have reflux. They're getting it because of belly pain or something. So you want to see a gastroenterologist, make sure that you're on the right therapy. And once you know that, then okay, well, you've been taking it for years. Do you want to get off of it? And so then we'll do the endoscopy. We'll see if you do have signs and symptoms of reflux. Also see if you have a hiatal hernia, and then also try to measure. In some cases, we'll do a manometry to see how strong the muscle is. And so once we determine that you do have the reflux and things are weaker and they need to be tightened, we can get you set up for an TIF procedure.
Perfect.
Currently, we're doing a lot of these with surgeons, and it's a combined procedure where the surgeon will actually replace the hiatal or repair the hiatal hernia first, and then what we do is anchor essentially the stomach and the esophagus together to make that muscle tighter.
Perfect. I did see a question that popped up. Can I have the TIF procedure if I have a 4-centimeter hiatal hernia? And
Yes, you can, but you would want that hernia reduced first by a surgeon, and we tend to do them together. So that's becoming a little bit more of a common way to do it. So the surgeon will go in there and he'll reduce the hernia, and then we will anchor everything together. Reduce it and repair the hernia, and then we will tighten up the junction.
Perfect. Karen, are there any other questions that popped up?
That's all that I have right now. So back to you guys.
Okay, perfect. So, you talked about, fundoplication and TIF. Maybe can you talk about, what are the differences between TIF and the Nissen procedure, or what could potentially, patients see that, what are the differences your patients that are coming to you, I'm sure you've been a gastroenterologist for many years, and you've seen patients that have come in that had the Nissen. Are there side effects for either? How are your patients tolerating the different procedures?
So as of right now, a Nissen's a little bit more invasive than a TIF is. So there is more, if you're doing what we call a straight TIF compared to a Nissen's, then your procedure on a straight TIF is completely through your mouth without any incisions or anything like that. However, obviously if you have to do the hiatal hernia repair before you do the TIF, then there would be an incision. So that's the combined procedures would have similar incision sites. Nissens are a little bit, surgeons do them, and the surgeons who do them do a really nice job on them. but they do have a little bit of a higher failure rate, where 75% of the people are back on a proton pump inhibitor in about 5 to 10 years. That's based off a study in the VA. It's a little bit older study, and as they get better at these procedures, I'm sure that number improves. A TIF has that benefit that even if it did fail, that to repair it is actually not as involved as going back in through a hole in your skin and going down there. We can just go in your mouth and put another stitch in, or 2 stitches in, or whatever we need to do. So the TIF procedure itself involves a device that goes through your mouth that has a stapler on the tip of it that allows us to use these, what we call tags, which are these, polyethylene
Fasteners.
Yeah, fasteners that help to, tighten up that angle or that juncture. So that's a major difference. Obviously, anytime you're getting a surgery done, there's always going to be some discomfort, and it's usually the less invasive the procedure is, the more likely you are to not have prolonged discomfort.
Okay. And I often hear patients who have had the Nissen, or people are fearful because they heard that, or they don't want to do anything. They're just going to stay on their medications because they're afraid to get the Nissen, because they're saying, oh, well, the doctor told me I can't belch anymore, I can't vomit, I'm going to have, constant gas bloat. Are you seeing kind of that same?
No, we're not seeing too much of that. I mean, obviously, there are going to be people who have that with both procedures, but it seems like, at least, and TIF is newer, so far, I think the experience is that you're not getting as much of the gas bloat and the what we call dysphagia, which is where difficulty swallowing because it's too tight. And most of the patients we do on it tolerate really well. The other thing is, people recommend a short hospital stay after a TIF procedure, but the last couple we did, we just discharged within like 6 or 7 hours. So, we watch them for a little bit and let them go. So I feel like the recovery time is going to be a little bit better than with a TIF than maybe a Nissen. Of course, you'll hear different things and read different things depending on what the views of the surgeon or the gastroenterologist are, but the data is very similar between the two.
Okay, yeah, that was going to be my next question to you, is what does the day look like, post-op, if you will? It sounds like you're doing them and they're it's same day. What can they expect? And then also, if you could talk a little bit about the diet or the post-op, kind of what are the things for recovery are they going to have to be cognizant about?
So I think symptoms-wise, I think up to 85% of people who get a TIF procedure have less than one heartburn episode a month, and I think for Nissen it's about 80%. So it's really, really, really similar. I think post-op, immediately post-op, you do have a pretty strict diet that we would give you, or the physician doing your procedure would give you, and it's, without getting into the nitty-gritty of it, you can expect for the first week or two to be on liquid or full liquid diet. Full liquid diet means milk products such as milkshakes and things of that consistency. And a clear liquid diet would be stuff like Gatorade and soup broth, that sort of thing. So you would be on a restricted diet for a week to 2 weeks after the procedure. There are some guidelines that are recommended by the company that makes the device. There are modifications made by each individual physician. So depending where you get it done, you may get a slightly different answer about what your diet is, but pretty restricted for about 2 weeks, and then you gradually add things in. And usually 4 to 6 weeks after the procedure's over, you're back to eating what is generally considered a normal diet. So one of the added benefits of a TIF is a lot of patients lose weight in the first month because you're not really getting that high caloric, unless you are drinking mocha frappuccinos every single day.
Or milkshake.
Peanut butter milkshakes. But
yeah.
now I'm hungry. So
I bet everyone watching are like, ooh, that sounds really good.
It's a restricted diet, but a long term you'll be able to eat pretty much what you want, but you do want to avoid overeating, and you want to be very cautious with gaining weight again after the procedure. And again, please don't understand the take-home message: this is not a weight loss procedure. This is, this is something that people tend to lose a few pounds, 5 to 10 pounds, just because the diet's so restrictive initially. But later on, as you improve your diet, then you just want to keep that weight off. So
yeah. And then what about physically? Are there going to be limitations? And then is it different if they get a hiatal hernia repair too, right?
Yeah. I mean, with any surgery that's going to repair any type of hernia, whether it's a hiatal hernia or otherwise, or a TIF procedure, you want to decrease activity that's going to increase your intra-abdominal pressure, meaning don't do sit-ups and squats and big weights initially. This is not a long-term change. You just have to know that for that. While you're healing, generally up to 4 to 6 weeks, we tell you to take it easy. Don't pick up heavy weights. Don't try to do a bunch of squats and sit-ups. Low-grade walking. Walking your dog, walking with your significant other. Initially is fine. After a week or two, you can start jogging a little bit. So it's just gradual. It's common sense. And again, every probably person who does this procedure has a little bit of a slightly different take on it. But in general, just ramp it up slowly.
Yeah, makes sense. We have a couple of questions I saw that just popped up. So Karen, I'll let you get through those real quick.
Perfect, thank you. I do have a question from Haley. She'd love to know how you learned about the TIF procedure and what are your patients saying post-op?
So yeah, the TIF procedure. Thanks, Haley. I learned about it. Well, I think I'm an interventional endoscopist. So what that means is I do procedures that are a little bit more complicated than your standard upper endoscopies and colonoscopies. So as part of that, we're kind of like the computer geeks of the GI world. So we tend to keep up to date on new procedures and new devices. So sometimes what will happen is at our conferences, you'll see a booth about a new procedure, and just natural curiosity, you'll go talk to the guys and they'll tell you about it, and then you try to get your hospital on board. So that's one way we learn about it. Other ways, obviously, through academic articles and journals and things like that. And then every once in a while, a new procedure comes up where you don't even know about it, and a sales rep hits the pavement and meets you and tells you about it, and that's how you learn about it. So a lot of different ways to learn about it. And what was the second part of the how did my patients done? So my patients so far have done really well with it. There have not had any major complications. I think, no one's had any complications. No one's had any major discomfort. I did have one patient who had some chills the next day, but she was fine within 48 hours. And we're not sure if that was from the procedure or anesthesia wearing off or something like that. So really, really well tolerated and no major complications or issues so far.
Nice.
We have just a thank you from Anna. She just says, thank you so much for sharing all this information. She really suffers, from gastritis. So
thanks, Anna. I appreciate the nice words.
And Stacy is saying that she wakes up at night, gasping for air, puking, and some liquid coming out of her nose. Is that reflux?
Yeah. So thanks, Stacy. And actually that, one thing I didn't mention earlier when we were talking about GERD symptoms is actually nighttime regurgitation and nighttime coughing. So those are two common symptoms people will have. The fact that you have acid and water coming out through your nose, it probably is, it's really significant reflux that would mean, and you should probably go see your local GI doctor and get evaluated. I would tell you that just without having, disclaimer of not being able to see you and assess you, I would tell you that you'd probably start off with at least getting the head end of your bed set up, and then see your doctor and get a referral to a GI, and then go from there. But you should not, in any circumstance, be puking in the middle of the night and having acid contents coming through your nose. That is something that needs to be looked at.
Yeah.
And Andrew, he asked that, can I stop taking my medication for reflux after my TIF procedure, and how will it change my lifestyle?
Yeah, so most patients are being able to get off the medicine. There may be 5 years down the road, things may loosen up. That happens with the Nissens. we think it may happen with the TIF at some point, but the good thing, again, as I mentioned, is a TIF, you can just go in and put a few more fasteners in to tighten things up. How it would change your lifestyle? It wouldn't. I mean, the only thing is that you would be quote unquote living GERD free, which means that you might not have to think twice before you have an extra adult beverage or coffee in the morning, or you might, you don't have to take another medicine every morning, and you can maybe save a good $20 to $30 a month with that, So that's the major lifestyle change. But yeah, just not having to be on an extra medicine, and all the things that can go with that, and potential testing for side effects. So that would improve. Again, the one thing I want to caution everybody is that nothing is 100% in medical procedures or in life. So, these things that I'm saying and that the company puts on their website is based off of data generated by hundreds and thousands of patients, right? Hundreds or thousands of patients. And so the vast majority fall in those categories, but there's always going to be outliers who don't get the same results, or maybe have much better results than other people. So just keep that in mind. So that I don't want to set anybody up to think that they're going to be, this is like this miracle and I'm going to be 100%, there are people who don't respond to these therapies, but most people do really well, and most people don't have to take any medicines.
Yeah.
I have one last one from Chad, and he's asking, can I get a TIF procedure if my Nissen failed? I've had a failed Nissen. Can I get a TIF procedure?
I believe so. I have to double check that one. I believe you can, but generally what you do want to do is just touch base with the surgeon who did the Nissens first, because it's just a matter of tightening. I have not done one of those yet. It is newer to me, but I believe anatomically you probably could.
Yeah. Thank you, Karen. There's just one other question I just saw from Allison. After TIF, would I be able to go back to a normal diet and eat foods I currently can't?
Yeah, I mean, not right after the TIF, but sure, several months down the road, absolutely. But again, it's common sense, and I think you want to talk to your physician who's doing that procedure to make sure that you're fitting with their guidelines. My patients have pretty much have figured out what bothers them, what doesn't, and they self-select for the food that they like. But I haven't had anybody on an extremely restricted diet 3-4 months after the procedure. Initially, yes, absolutely, you got to follow the diet, otherwise the TIF will fail. And the Nissens will fail. I mean, any gastric or esophageal surgery, if you don't follow the recommended diet, you're going to have problems down the road.
Perfect. Okay, I just saw what before we go. I was gonna close up, but there's one last question. This is from Matthew. If a lynx fails and is removed and my symptoms persist, can I get a TIF?
That's going to be a little bit more challenging, because to remove a lynx, they've got to go in laparoscopically. So a lot of those surgeons, if you want to repair, they're just going to go ahead and do a laparoscopic hiatal hernia repair or Nissen when they're there, because they have to dissect the lynx off, and that's not a competitor, but it's a different type of anti-reflux surgery, and so that's done entirely surgically, and the removal of it is surgically as well. And there's a lot of scar tissue that forms when that happens. I mean, technically you could do a TIF, but it probably wouldn't be the right thing to do, only because I think the surgeon in there would want to try to do everything at one time, so you're not getting several procedures.
Yeah, perfect. Okay, I'm breaking my promise, Dr. Sachdev.
No, that's okay.
There's one more question. Okay, this is the last one. And it's a good one. Miguel's asking, will you do the TIF procedure if you have esophageal motility problems with spasms?
So it really depends. I mean, if you have something called achalasia, which is a motility issue, there is some data coming out to say that people who get that repaired can get a TIF afterwards, but not at the same setting. Some motility issues, such as a esophagus that doesn't have any motility to it, a TIF might make it harder for food to go down. So really, I think it's a very good question, but it's also one that has a lot of different variables. It's one of those ones that you can go 8 different ways because there's so many different motility disorders that we talk about. So best get is just to get in with the GI or esophageal surgeon. Just make sure you have an exact diagnosis of your motility disorder, and then make sure that you can you qualify.
Yeah, it's perfect. Thank you. So I'm gonna close now. You're very popular, Dr. Sachdev. Everyone wants to ask you questions. So with that said, are there any last recommendations or advice that you give to these people that are watching that are suffering from GERD? What would your advice be to them?
Well, number one, get your GERD treated. The underlying thing that we have to remember about GERD is that GERD can lead to cancer. Again, it's not the majority of patients, but the minority, but it does, and it can lead to swelling in the esophagus, strictures. It can lead to difficulty swallowing. So GERD needs to be treated. The second thing is to get evaluated for it properly. Make sure you see a physician. Start with your primary care, so you can get the proper referral to a gastroenterologist or to see if you have symptoms from that. Or your symptoms are related to that, excuse me. And then once you get all that, and you have your scope done, then you have to see, is this a short-term course? Is it, do I need PPIs or acid blockers just for a few months of my life? If that's the answer, then, you probably don't want anything more permanent than that. But if you're going to be on a medicine that's long-term, then you want to look at what are the potential side effects, what are my personal risk factors for those side effects, and that's an open discussion with your physician. And then after that, what are my alternatives? And then we're talking about the surgical ones versus the TIF versus whatever. And then, that's where you have to see the expert in that to make sure you're the right candidate.
Perfect.
But basic things.
Yeah. Go see your doctor, right? They don't have to suffer anymore. We always say, be your own advocate.
Yeah.
Well, thank you again so much, Dr. Sachdev, for joining us. If you're in the Phoenix, Arizona area, you can search for Dr. Sachdev, and I'm assuming come make an appointment with you. But if you are not in the Arizona area and you are looking for a TIF-trained physician, you can go to gerdhelp.com, and there is finder there. You'll be able to code in or your state and find a TIF-trained physician near you. So Dr. Sachdev, thank you so much again for joining us this evening. We really appreciate it. And I know everyone watching and everybody who joined and asked questions really appreciate it. Thank you, Karen. Thanks, everyone. And I hope everyone has a safe and happy holiday. So thank you very much.
Thanks, guys. I just want to add one last thing on that. On the GERD Help website, the reason you should use that website is that not every gastroenterologist or surgeon does a TIF, right? So the GERD Help website, the people on there have been trained and have gone to the courses for it and all that. So those are the guys who actually do those procedures. So you definitely want to get your referral and not just think, oh, I got to go to random Dr. XYZ. You got to make sure the people know how to do the procedure. So definitely go there and look it up. So
I love that. Thank you so much, Dr. Sachdev. That was perfectly said. I appreciate it. Thank you so much again, everybody. Have a great night, and we'll catch you next time.
Thanks, guys.
Thank you.